All right. I hope everybody notices that it's gotten warmer in the room, not only because of the warmth of our interactions and conversation. Thanks, the temperature's been adjusted. And it's my pleasure to introduce Dr. Chad Brummond, who will be moderating the third panel. Dr. Brummond has been my counterpart at the University of Michigan. He is an associate professor of anesthesiology, the director of pain research, the director of clinical anesthesia research at the University of Michigan, where he also co-directs the Michigan Open Prescribing Engagement Network, better known as Michigan Open. He's been an absolutely wonderful colleague in the planning of these two summits. Dr. Brummond.
Well, thank you, Mary. And I actually want to start by thanking you and Dean Williams and President Bacow for inviting Michigan out here to share. And I want to take a minute to thank Rebecca, Veronica, and Natalia. You've been terrific today. And can you guys stand, actually, please? Because you've just done a tremendous job in organizing today and making sure everything goes. And so really appreciate your help. Thank you very much. So I'm Chad Brummond. I'm an anesthesiologist and a pain physician by training. And I work on the other end of this, but yet come close to the ideas of opioid use disorder, opioid addiction, and substance use disorders in the perioperative care. Our team is really focused on how to prevent new opioid use disorder and prevent excess in the community, those pills that can really become access to vulnerable populations, including teens and adolescents. And what's been interesting about this process is that I'm an anesthesiologist, I'm a clinical researcher, I've been doing work in acute to chronic pain for a number of years, and thinking about it as a researcher kind of in a classic, nerdy researcher way, and not really coming back forth and thinking about policy and how policy drives care. But this process and our current opioid crisis has led me to this point of actually thinking about policy. And the most striking and memorable experience was going to Lansing with our Institute for Healthcare Policy and Innovation, where Michigan Open lives, and having the ranking Senate Majority Leader look at me and say, "Help me make my policy better." And I was unprepared. I'm a physician. I think about care. I think about lots of different aspects of care and research and outcomes, but I hadn't thought about policy. And as Professor McQuaid noted in the last session, we've had many policies come through the state of Michigan, some well-worded and some poorly worded, all well-intended. And I wasn't there to help those policies. And I think it was an eye-opening moment as a provider to consider the fact that it is partly my role to consider how policy works. And I think another interesting aspect of Michigan Open and our work in Michigan, and a unique factor in our state is that we're effectively a three-payer state. We have Medicaid, Medicare, and Blue Cross Blue Shield of Michigan. And Dr. Bonner today will talk a little bit about Blue Cross and their unique approach to the opioid epidemic in the state of Michigan. But what's been interesting is to bring a public and private payer together. And Mary and I did a really fun podcast before this event and talked a little bit about that public-private relationship, where we can really get our payers together to think about payer solutions. And I will give Blue Cross Blue Shield a lot of credit for thinking about innovative solutions like payment incentives for better care. And those have been in part for surgeons and hospitals, but now looking at how those work in MAT as well, and Dr. Bonner will probably cover that as well. We have three distinguished panelists today. I know it's sunny and warm outside, and you've avoided all that beautiful Boston weather today, but I'm glad you did, because you've got three really wonderful panelists, and this is going to be a lot of fun. Our first panelist is Richard Frank. He is the Margaret T. Morris Professor of Health Economics. His research is focused on economics of mental health and substance abuse, long-term care financing policy, healthcare competition and implementation of healthcare reform and disability policy. He has served as the Deputy Assistant Director, Secretary for Planning and Evaluation in the Department of Health and Human Services, directing the Office of Disability, Aging, and Long-Term Care Policy from 2009 to 2011. From 2014 to 2016, he served as the DHHS Assistant Secretary for Planning Evaluation. Dr. Frank served as the editor of the Journal of Health Economics for 9 years. He was awarded the Carl A. Taub Award from the American Public Health Association and the John Eisenberg Mentorship Award from the National Research Service Awards. He is a member of the National Academy of Medicine. He received the Academy Health Distinguished Investigator Award in 2018. He also is a co-author with Sherry Glide for the book Better But Not Well in Johns Hopkins University Press. Dr. Frank received his BA in economics from Bard University and his PhD in economics from Boston University. Our second speaker is Michael Botticelli. He is the executive director of the Graykin Center for Addiction at Boston University Medical Center and a distinguished policy scholar at the Johns Hopkins Bloomberg School of Public Health. Prior to this, Michael was the director of the National Drug Control Policy for the Obama administration. He joined the White House Office of National Drug Control Policy, ONDCP, as the deputy director in November of 2012, and later served as the acting director. Mr. Botticelli has more than 2 decades of experience supporting Americans affected by substance use disorders. Prior to joining the ONDCP, he served as the director of the Bureau of Substance Abuse Services at Massachusetts Department of Public Health, and we heard about some of that great work earlier today, where he successfully expanded innovative and nationally recognized prevention, intervention, treatment, and recovery services for the Commonwealth of Massachusetts. He also forged strong partnerships with local, state, and federal law enforcement agencies, state and local health and human services agencies, and stakeholder groups to guide and implement evidence-based programs. Mr. Botticelli holds a Bachelor of Arts degree from Siena College and a Master's of Education degree from St. Lawrence University. He is also a person in long-term recovery from substance use disorder, celebrating more than 28 years of recovery, and that deserves a round of applause. And our third speaker is Dr. Amy Bonnert. She is a mental health services researcher with training in public health who focuses her research on epidemiology and brief interventions regarding substance use and related disorders. Within a team of collaborators at the University of Michigan and the VA, she has led a number of projects related to overdose and prescription drug safety. A number of her research activities have been specifically aimed at improving care occurring in substance use disorder treatment settings. Dr. Bonnert has demonstrated a particular expertise in applying epidemiology methods to the analysis of VA electronic health records and data sets for questions about health services delivery. Dr. Bonnert earned her PhD in public health at Johns Hopkins University and completed her postdoctoral fellowship with the Department of Veterans Affairs National Serious Mental Illness Treatment Research and Evaluation Center in Ann Arbor, Michigan. While on her postdoctoral fellowship, she became involved in work concerning suicide, substance use, and opioid medication safety in the veteran population. She has an appointment as an associate professor in the Department of Psychiatry at the University of Michigan. Dr. Bonnert is also affiliated with the Department of Veteran Affairs Center for Clinical Management Research, CCMR, and an HSRD Center for Innovation. So join me in welcoming our panelists. So first, invite Dr. Frank to come on up and get us going. Thanks.
Thanks for having me here today. It's really been in many ways, a moving day, and I'd just like to announce that the inspiring part of the program is over now. He said that to me in the Situation Room at the White House. Let me touch on where we are today in terms of treatment. We face a situation where somewhere between 10 and 25% of the people with an opioid use disorder get treated for it. Among those that get treated for it, about 34% get treatment that would be likely to get them better. And then among those that get medication treatment that is likely to get them better, about 40% stick with it for over a year. So if you do the arithmetic, that means on a good day in this country, 3.4% of the people with an opioid use disorder are getting the treatment that's likely to maximize their chances of getting into recovery. Okay? This is a problem that needs fixing. I want to touch on two areas of policy that are aimed at remedying or addressing this situation. The first is a set of policies that would equip organizations and individuals that people with an opioid use disorder touch to get them either engaged in treatment or to get them to some place that will be able to engage them in treatment, and to do so efficiently and effectively. The second area I want to talk about is approaches to developing financing arrangements that will promote investment in the substance use treatment infrastructure in this country. Recall that until very recently, virtually all the money that was coming into the system was coming through SAMHSA block grants. It had been neglected for 50 years or so, and essentially had been put in place in the 60s and 70s and hadn't really changed since. So we had a sort of a franchise system that had been stagnant for 30 years or so. So let me start with some of the mechanisms that we might use to drive people towards evidence-based treatment. The first thing I'd like to touch on is related to the accreditation system in this country. And what I'd like to propose is that we develop a set of accreditation standards and evidence-based practices in the regulation or in a sort of quasi-regulation of substance use treatment programs that drive people to facilities where they're likely to get treatment that works. And the reason I sort of focus on that is that today, too often, you can get JCHO accreditation, CARF accreditation, and be a facility or a program that will not use medication treatment, will not make that available, will not necessarily refer people to programs that make that available, will not drive people to a warm handoff on their way out of the treatment program to a community program, and will often create financial rules about participating in the program that will impede recovery on the back end. Let me touch on that a little further. For example, when somebody comes into a private treatment program, very often they're asked up front to show their credit cards. And just consider a typical person, statistically, who has an opioid use disorder. They tend to be young. They tend to be not very well off. They tend to be somewhat downwardly mobile economically. And they're going to leave that program possibly with a $40,000 debt. The chances of them getting back into the community and succeeding with that kind of pressure on them dramatically reduces their chance of a successful recovery alone, regardless of what treatment is offered. So for that reason, I think it is imperative that we use federal resources, that we use federal deeming arrangements, state deeming arrangements, so that when these accreditation organizations are doing their work, they're doing it based on evidence-based standards, and that all the programs that they accredit are doing things that will get people better and will not create impediments to their recovery. The second area focuses on state licensing. As I said a moment ago, states have largely put in systems that governed their substance use disorder treatment systems in the 70s and sometimes the 80s. And they haven't often revisited things like licensing standards. So too often, we're in situations today where programs are licensed, receive substantial federal funds because of those licenses, and do not do anything that resembles modern healthcare and modern science. And there are a few states that have started to take the initiative to do things like require that medication treatment is at least on the menu, that people who have been treated with an opioid agonist can be treated. So those are two important, I think, mechanisms we have for driving people into treatment. Let me now turn to financing. What we've seen recently is we've seen a lot of new money poured into the substance abuse treatment system. The 21st Century Cures Act put in $1 billion over 2 years. There are several $1 billion of new money that have come through the Support Act. And in each case, these have been done as grant programs to the states. Now, there's two issues that come up with that. One is that there's very little accountability in place about how that money is used. And so if you go down the list of things that are being used, there are lots of things that are known to be effective and are known to be important, but there are also lots of things that are known to not be effective and have been shown in rigorous studies not to work. So for that reason, I think we need to put into place some accountability program. More importantly is if you look at the way the money has been spent to date, the states that have expanded Medicaid, for example, have invested in infrastructure. That's because they knew they had a source of revenues coming to pay for services. The states that didn't expand Medicaid bought services and did nothing to increase the infrastructure, therefore not setting us in a good position for the future. So to deal with that, my proposal is that we set up federally, work on a mandatory program of funding for substance abuse disorders broadly, not necessarily tied to opioids alone, but that will put into place a predictable sense of a predictable source of financing, which will then create incentives for states to make the long-term infrastructure investments that are needed to actually equip us for the future. I'll stop there. Thank you.
Good afternoon, everybody. Thank you for the invitation to be here today, and it's a great pleasure. As much as I kid Richard, I had the privilege of working with him during the Obama administration, and like to think that we accomplished some good things together, Richard, so I really appreciate you being here. I'll just start by saying, I want to pick up where Richard left off. For 10 years, I was the director of addiction treatment services here in Massachusetts, right? And, you know, the financing of addiction treatment is really a complex tool, and I can't underscore, you know, the need for a stable, reliable, and predictable funding base for addiction treatment. So my job, quite honestly, at the state level was to piece together state appropriation, federal appropriation, discretionary grant portfolios, and Medicaid funding to try to develop a coherent system of care. And I can't tell you, even in a state like Massachusetts, where we have near universal health care, where we have a significant support from the both executive and legislative branch, it's very, very difficult to develop a comprehensive continuum of care when you're piecemealing care together. And I'll talk a little bit about our work as an accountable care organization and what I think payment reform brings and opportunity it brings to this table. I'm going to say two things that are probably heresy here at Harvard. One is I'm not going to use slides, and I'm glad Richard is not using slides. But as I was transitioning to the federal level, and my good friend Dr. Howard Koh is here, I had part of my time at the health department was working as his chief of staff, and I won't tell inside stories, but having straddled the world of science and public health and politics for a very long time, I've learned a very valuable lesson, and that science and data don't drive public policy. And we delude ourselves if we think that we're going to move the needle by science, in terms of public policy, by science and data. So in one of the earlier panels, one of the participants asked, how do we change public policy and change people's hearts and minds? Is it resources or stories? And my standpoint, and I think this is substantiated by a number of studies, that science and data are insufficient to move public policy. And by way of that, I'll share a study that was done at Johns Hopkins Bloomberg School of Public Health. And they were looking at support for policies around naloxone and naloxone distribution. And what they found was really interesting, right? So if you presented people with the data, public support goes up a little bit, right? But if you combined data with sympathetic narratives, that created the greatest change in terms of people's minds, right? Study after study show, regardless of your political stripe, that we're all victims of confirmation bias, right? So we have a tendency to basically take in data that validates our own position and disregard data that doesn't. And that actually emotion seems to change people's minds more than science and data. So how do we use this to our advantage? Well, first of all, those of us in the public health world, many of us are here and have been doing this work for a long time. We have a tendency to be navel gazers, right? We look at our own navel, we say, woe is us, no one will believe us, right? So one of the things that I think we have to look at in terms of how do we change public policy is how do we use unexpected messengers, right? And Lieutenant Glynn is here. And one of the most effective things, so Richard and I were tasked, we're trying to get the president's budget to get $1 billion appropriated by Congress at a time when they weren't giving out money. And one of the most effective strategies we utilized is we brought 50 sheriffs to the White House, and then we sent them loose on Capitol Hill, not to advocate for more law enforcement officers or more drug task force, but to advocate for treatment funding, right? Because they expect us to be the messengers around that. So how do we use unexpected messengers to really try to drive public policy and messages? The second is how do we use personal narrative to change public policy? And I will say this in a very personal way. So I had a great privilege. It was a really great day, a really great week to be in Washington when the Supreme Court upheld the Affordable Care Act. And it was also the same day that the Supreme Court legalized same-sex marriage. My husband and I happened to live on Capitol Hill, and we walked to, I still get so emotional when I talk about this. So we walked to the Supreme Court and celebrated with hundreds of other people there that day, and it was profound. And of course, I've been doing substance use work for a long time, and while I was incredibly happy, I couldn't help but think, my God, how far we've come in 50 years in terms of changing public policy, and how far we still have to go, but on this one single issue. Yet, despite the fact that we know that addiction has been a disease for a very long time, we have failed to move public policy in that direction. And I think we have to acknowledge, and as we've talked about templates today, templates for change with other stigmatized diseases and other stigmatized people, that in no small way we move public policy around same-sex marriage by the simple fact of people coming out to their family, to their friends, to their employers. Addiction has always been considered a disease of other. And part of what we have to do in diminishing that is using our personal voice and our personal narrative to change people's opinion. So I've been doing this work for a very long time, and I've been honored to be in very, very privileged positions. And I've always been very public about the fact that I've been in recovery to use my personal narrative in ways that are appropriate. Throughout the course of ONDCP, that office has been led largely by law enforcement officers and largely by people from the criminal justice and military world. And I was the first person with a public health background, and I was the first person in recovery to hold that position. And we need to use our voices to change that. So I'm running out of time here, as I always do. But I also want to talk about just a couple things of areas of improvement as I think it relates to access to treatment. One is completely reframe our thinking about this issue and who we fault for not being treatment seekers. So Dr. Frank talked about the small percentage of people who actually get treatment, but I want to focus on the larger group of people who don't get treatment. And even our federal data basically look at that larger pie and talk about those as people who did not seek treatment. So we put the entire locus of responsibility for people who do not get care on the person with the disease. And we don't do that in any other way, right? And so if we shift our thinking about these were people who did not get care, it shifts the focus of responsibility and frames it differently and calls on systemic approaches to deal with that population, right? And those are exemplified in words like that we still expect people to hit bottom to get the care that they do. Barbara and McQuaid let the medical community off the hook, and I'm going to put them back on the hook. Because quite honestly, this is the only area of health where we let healthcare providers treat this as an optional healthcare activity, where we don't routinely screen, intervene, and treat people for this disorder. I am really thrilled that Michigan is actually incentivizing physicians. At the same time, I am desperately sad that we have to pay primary care providers to get waiver training and to bother to treat people with addiction. I think it's absolutely deplorable. So one of the things under Kate Walsh's leadership at BMC, we have actually made it a requirement that the vast majority of our care providers have to train, have to go through the waiver training. We've just said it is not an optional healthcare activity for you anymore. So, and I'll have to say this, the police, quite honestly, have stepped in ways that our healthcare community should be ashamed of ourselves in terms of the work that the law enforcement is doing in this epidemic. I'll say a couple more things and then I'll close. One is, the Reverend who is here, I think it's really important if we, again, want to look at other templates. During my time working on HIV and AIDS, the faith community played a huge role in diminishing stigma and tending to their congregations. And I think we should engage our faith communities in much more meaningful ways. Two other quick things. One of the areas that's emerging that we've been doing some work on at the Graken Center is that employers are certainly understanding not only the financial impact of this disease, but also understanding that they can't hire people in a tight labor market, in understanding that they can play a role in culture of climate. We often go to payers to think about setting up their benefits, but I think that part of our work should be how do we work with employers to think about things like what should a good benefit structure look like? How do we think about changing the culture and climate within organizations to allow people the freedom to ask for help? If you look at data from the National Survey on Drug Use and Health on why people who even know they need care don't seek care, it's often their fear of what their employer is going to think and fear of their professional development. The last thing I'll say here that I think is a tremendously underutilized tool is litigation. And I think we've seen in other areas of healthcare, particularly in the mental health world, where we have used litigation in ways that, quite honestly, I've been doing this work for almost 30 years. I'm tired of educating people. I'm tired of asking people to do something that they actually should be doing. And one of the things that I think has been successful is the use of the Americans with Disabilities Act as a legal leverage to making sure that people actually get people on a medication. And the U.S. Attorney's Office, while he's been opposed to safe consumption sites, his Civil Rights Division has been really aggressive in pursuing cases, particularly within the criminal justice system where they fail to allow people on medication. We were actually signed on to the amicus for the Eldred case, where we basically criminalize relapse. So this was a case where a woman who was under probation control without any subsequent criminal activity and was still engaged in treatment, but as we know, relapse is always a condition, and she was thrown back in jail as a condition for relapse. So how might we use our laws and litigation to support good treatment? And then the last thing I'll say, and I know I'm over time, one of the things that Massachusetts has done in the next iteration of healthcare reform is move the vast majority of Medicaid patients onto accountable care organizations. So Boston Medical Center is one of the largest of those accountable care organizations. And it's very hard for a chronic disease When your payment model is to pay for a bed day, and to not, and we know that the biggest success is people's duration in care. So operating in a fee-for-service system with a chronic disease, you can see the kind of challenges with that. But one of the things that we have learned as an accountable care organization is that when you look at the top utilizers of our services, the biggest predictors of top utilizers are untreated substance use, untreated mental health, chronic disease, and homelessness. And changing the payment and delivery model has actually allowed us to think outside the box and how, as an accountable care organization, we can begin to address some of those social determinants of health that we know contribute to bad health conditions. So, as an example, one of the things we invested $6 million in housing development opportunities for our patients. So I think there is great promise in accountable care organizations and payment reform. So thank you very much, everybody.
Do you know how I move forward the slides? Is it going to be that? Okay, perfect. Thank you. Good afternoon. It's so invigorating to be here as part of the conversation today. Lots of energy in this room. I'm a health services researcher by training, so I've done a lot of work doing pharmacoepidemiologic methods to inform opiate prescribing guidelines, evaluate those guidelines. What I'm going to talk about today is a project that had nothing to do with any of that, but it's been one of the most rewarding things I've gotten to be involved in, and had the honor of leading a project that is focused on improving access to medications for opioid use disorders, and specifically in primary care. You might ask, why in primary care? Certainly, it's a challenging place to implement new treatment. They're already dealing with so many different problems and feeling very overwhelmed. There was a couple different reasons why this is an important area. The number of people going into addiction psychiatry specifically, unfortunately, are low enough that it will not meet the capacity needs for treating all the people with opioid use disorders. It's also the case that sometimes going in those traditional addiction treatment settings carries a lot more stigma, and seeing your usual primary care provider has less stigma, and also that you have the ability to treat other conditions simultaneously. So potentially you're getting a patient in for what might feel to them is the most pressing issue, their opioid use disorder, but you can address some of their other health conditions as well. The third reason being that there's actually a pretty extensive evidence base that models of delivering these care in primary care work. So in a project led by my colleague, Dr. Lagasetti, who you heard from this morning, she reviewed the evidence on different models of, sorry, this hops around a little bit more than I was anticipating, of delivering primary care medications for opioid use disorders, and found that basically everything seems, there's quite a lot of options. A lot of different things seem to work. You can do this in a way that's tailored to the resources of your particular clinic. So having something that's multidisciplinary, that does pull in addiction experts, that works great. If it's physician-centric, that works fine too. You have it led by advanced practitioners, nurse practitioners, physician's assistants, that also works. Having handoff between clinics, so what's known as a hub and spoke model, where you have specialized treatment centers that are able to help patients when they're at their most, their symptoms are the most severe, but then when that patient is stabilized, they can go to a primary care clinic that's better situated for dealing with someone who's in more of a maintenance of treatment. That works well. There's lots of different models, some of them developed specifically here in Massachusetts, actually. So with that background, we developed the Michigan Opioid Collaborative Project in 2017 to, I'll go ahead and hop through all these, to try and help clinics use these models in their systems. The funding for this came through the state opioid response and state targeted response programs from SAMHSA. So this was a subcontract from Michigan Department of Health and Human Services to the university. We work in close partnership with the MDHHS staff, which has been wonderful, and now just started partnering with Blue Cross Blue Shield of Michigan. So as Chad said, we have all three payers in Michigan as partners now. We started with the goal of essentially mimicking a successful program in Michigan called the MC3, the Michigan Child Collaborative Center program, where they help physicians, particularly in more rural areas of the state where they don't have expertise around dealing with child psychiatry issues, by giving same-day consultations and teleconsultation for those types of issues. So we really wanted to start at the end down here, where we were going to do same-day consultations, and thought that we'd be able to help providers who maybe had fairly small numbers of patients they were treating with medications for opioid use disorders, or had the waiver but weren't using it because they felt like they didn't have enough practice. What we found when we got out and talking to the specific communities we were working in is that there was actually a lot of energy with people who had come to believe that this was important work. This is their job as primary care physicians, but had no training at all and wanted some. So we kind of took the program back a couple steps and started offering waiver trainings. We got a number of people, a number of the addiction psychiatrists in our group up and going with being able to do the waiver trainings, getting approved through ASAM to do it, getting practice doing it. The others that were in the state we absorbed into our program. And we also give a lot of technical assistance at a clinic level. So we will send people to your clinic and talk about how to do injections for Vivitrol, talk about how to do urine drug screens, how to interpret those results. Simultaneous with all that, we have behavioral health consultants located at a community level who talk to all of the physicians they can in the community, find out what resources they need, find out where there's treatment openings, help build bridges between those, help try and work towards hub and spoke models, and also offering other webinars. With this program, we have been able to take 128 providers from not using any medications for opioid use disorders in their practice to actively prescribing to their patients in the 2 years. The big numbers here are the zones for our CMS regions, but a particular point of pride with this was the Upper Peninsula. So the green area up there is very rural, very separated. When we started this program, there were 2 physicians in all of the Upper Peninsula who were prescribing medications for opioid use disorders, and we've since added another 8. That's been a particularly great area to expand. Unfortunately, now we're running into a problem with pharmacies not wanting to stock the medication. So you fix one problem and there's another. We just started partnership with Blue Cross Blue Shield. So they just announced this will have a couple different steps. In the first year, for physicians who work with us, who go through one of our trainings, once they start treating their first patient, they will get $10,000 as an incentive from Blue Cross Blue Shield. And then if they get up to 10 patients, which is about moderate panel size, by the end of the second year, they get an additional $10,000. And then the physician organization they are part of is able to receive additional funds to help support broader efforts. And the physician groups, as we started to have conversations about this, some I think will take that as additional incentive pay. Some will pull that resources across a couple different physicians in their group to support additional services, having additional case managers, other things like that can help facilitate a more comprehensive approach. Once this gets up and running, and for people who are already existing providers, they will get what's called value-based reimbursement. So for providers who offer this treatment, they get 5% higher reimbursement for the same exact treatments for all of the care they deliver than other providers. And then now they're working on a third step, which will be increased reimbursement for the other care team members. Before we start our panel discussion, I just wanted to mention one more study led again by my colleague, Dr. Lagasetti, where she looked at changes in access to treatment and specifically to buprenorphine using this national NAMCS data, which is a sample of primary care visits. What she found is that as access to buprenorphine expanded, and I saw from the data this morning it's going back down as well, but really all of that benefit was experienced by white patients. Similarly, the vast majority of the increase was experienced by patients who either had private insurance, so most likely were employed or had family members with good employer-based insurance, or who were self-paid, so who had enough financial resources to pay for care. So I think as we work on all of these efforts to improve access, obviously I'm a big believer that this is important, but I think we're not paying enough attention to making sure it's reaching everyone, not just those with already more resources. So I'm looking forward to our group discussion.
Thank you all very much. Those were three engaging lectures, and it really set the stage for this discussion about policy and financing. And I want to start with the questions of policy and really ask each of you to comment on what policies are most important barriers to expanding access to treatment for using medications for opioid use disorder. Amy, do you want to start?
Yeah, I have a thought. A couple times the idea of Xing the X waiver has come up, right? So eliminating the 8-hour training requirement and the additional paperwork to be able to prescribe buprenorphine outside of specialty addiction treatment programs. I think that makes a lot of sense. What I see in our program is there's still a lot of hunger for education. So I think in some ways taking that training out of meeting a regulatory requirement framework, but being sure we still put resources towards that education, I think will be important, and also be able to be more, this is a fast-moving area in terms of the research. So to do it the regulatory way, that those slide decks for the presentations have to be approved years before they're actually being used, it can be more adaptive to new information that's coming up and hopefully improve the quality of care.
You know, one of the areas, and actually Commissioner Burrell and Jeffrey Salmon and I wrote a letter in the New England Journal of Medicine. You know, if you look at our current laws and regulations as it relates to methadone treatment, they've been in existence for, 50 years. The regulatory and legal burdens are challenging. Basically require, and largely because of NIMBY, they're often cited in like the most challenging places in town to go to, require people to go nearly every single day for 6 months before they're even eligible for take-home medication. And despite all of those burdens, people do really well on them. And you know, I think it's time for Congress to really look at our methadone treatment regulations, and I think we've seen with buprenorphine and others that particularly we can integrate this care in primary care settings in these really highly destigmatized environments in ways that work for our patients. It was very interesting after, and I need to share this, after we wrote that editorial, you know, we got significant pushback from the opioid treatment provider community, as well as from SAMHSA, saying that they had no interest in looking at these regulations. So I think it's an area. One of the other things that I want to say that I think it can become, the bedrock of addiction treatment is predicated on the confidentiality of treatment. And right now we are in the midst of a discussion about 42 CFR, which is the confidentiality laws. And I know that people have different opinions about it, but I think it's really, I think we need to be very, very cautious about what we do with those confidentiality laws in a highly stigmatized environment. So while it's not a barrier now, I worry, so for instance, SAMHSA just put out a notice of proposed rulemaking that would actually make it easier for law enforcement to get the records of people in treatment programs for a whole host of crimes that they were never interested in before, including drug trafficking. So I think it's worth noting that could be, I think, a really potential issue for us.
I guess I would point to three things. Two of them have to do with Medicaid. First one is expand Medicaid. If you just look at where the expansion of treatment for low-income people has happened, it's happened in expansion states with buprenorphine, huge increase there, almost flat in the states that didn't expand Medicaid. So that's one. Two is the content of Medicaid. There are still too many states, even among those that expanded, that don't cover the full panoply of drugs for treating opioid use disorder. And we, you know, that's the complement, because if even if you change the rules on methadone, if you don't pay for it, you have a problem. It's also important to remind ourselves that about a third of the people who don't get treatment say that it's either an availability or a cost problem. The last thing I would say is not so much on the payment side, but on the education side. I am struck by the result where we've had huge positive things on randomized trials of starting people on buprenorphine in emergency departments. And that's a great success. But if you look closely at those data, you'll see that most people who are offered it refuse it. In fact, the vast majority, like 90%. So we have the technology. You need to figure out how to engage people. And just training people how to do the drug without training them how to engage folks is never going to get the job done. So I think that really focusing on ways to engage people in treatment is very important.
So, Mr. Botticelli, one question I guess I would ask is, we brought up the DEA X waiver and you know, whether this is an appropriate policy, whether it's necessary, but yet still heard sort of a hunger for education among primary care providers in particular, that as they move down this path of new treatment, new cohort, that they still want that education. What other barriers, though, do you see besides the X waiver training that seem to hold providers of all types, but in particular primary care providers, from getting involved in treatment for opioid use disorder?
I think it starts, and you know, I think Amy's project and most projects that have looked at integration of primary care kind of the same thing. And you know, a lot of, and I'm not speaking just on my behalf, a lot of people at BMC actually do a fair amount of waiver training. So I'm kind of channeling them. You know, and it's not the X waiver. It's really the case consultation that seems to be the linchpin in terms of getting folks to actively treat people. And I'm not a doc, but my experience with a lot of physicians say, like, once you give them the toolkit, they realize this is pretty easy. It's really not a difficult task to be able to do it. So I think that's really important. But I think that, you know, one of the things that's happened here in Massachusetts, and I think needs to be replicated across the country, is we had all of our medical schools come together. So I think we have to back up education, not just in medical schools, but in all of our medical professionals, and say, what are really core competencies that we feel are important to embed in people's medical education? So, you know, again, here in Massachusetts, all the medical schools came together, developed a core competency curriculum. I think Pennsylvania has now done the same thing. But we really have to back this up, because I don't think that we're providing people the education within their medical education to really feel comfortable even kind of beginning to treat folks. And I think it's one of the reasons why we've seen so few primary care providers who have actually even gone through the DEX waiver training or have gone on to treat. So I think it's about you know, backing up education, and how do we think about case consultation and support.
So within that case consultation, Dr. Bonner, you've had some novel approaches to the sort of the case consultation approach in Michigan. Would you be able to talk about those?
Yeah, I mean, I think one thing I didn't mention in my talk relevant to the broader themes of today is a frequent theme in those consultations ends up being stigma, and going back to this bad actors thing, right? So someone who's calling for consultation saying, hey, I have a patient whose urine drug screen came back positive for cocaine. I'm going to cut them off the drug. Just wanted to run that by you and make sure I'm doing this the right way. And being able to say, actually, that medication wasn't treating their cocaine use disorder. Probably what they need is more support. How could we, you know, think about the other services you could get them involved in? So, and just it being an opportunity to model how you talk about patients, all of these kinds of leading by example type themes that have come up with the different programs. It I think ends up being a mechanism to expand that beyond within just one health system, but a broader reach of it.
Great. I am going to open up the questions here in just a second, questions from the audience. So, but as you get there, Dr. Frank, what role do you see the settlement funds from all these various lawsuits? Where do you see that money going, and the role of the lawsuits to the state and local governments with respect to paying for treatment and harm reduction?
Yeah, so we're seeing the beginning of that starting to emerge with the bankruptcy and the sort of proposed settlement from Purdue. I think there's a few facts we have to face up with, which is the money that states will get will be less than the square root of what they think they lost, because there just isn't that much money out there. Second is the lawyers, and I think some of the attorneys general are strongly committed to not making the errors that happened in the tobacco settlements, which is where the money went into potholes. And so what what both those things imply is that having very evidence-based abatement plans is going to be of critical importance here. And for example, if you looked at the Oklahoma abatement plan, that is a list of anything that everybody's ever tried in the addiction area, and including things that have been proven to be not workable. And so I think it's really going to be pulling together the evidence, making sure that it's scalable at the state level, and making sure that the opportunities available are sensitive to the cultural and political milieus of the states. And I think if they can get both technical assistance from the experts and the courts in sort of guiding that, that might lead to a more happy resolution than we saw in the tobacco settlements.
So just following up, maybe from Mr. Botticelli or Dr. Bonnert, how much of that focus in terms of this settlement should be on bigger issues or potentially antecedent issues such as pain and untreated behavioral health versus the treatment for opioid use disorder or substance use disorders? I mean, do you see a role for both as we start to potentially parse out settlements like this?
I'll take a stab at this. I think we have to acknowledge the nexus around kind of the opioid predicament, why we got here, and pain management opportunities. So I do think that there are significant opportunities here as we think about kind of leaning in, kind of absent insurance reimbursement for alternative pain management strategies. So, are there opportunities to really think about kind of longer term systemic changes that are not just going to focus on kind of treatment, which is, I still think, a significant need, but, how do we really think more upstream around, even beyond kind of primary prevention, but thinking about prevention and looking at things like alternative pain management strategies, so that we're not, in essence, creating situations where people are not getting adequate access to pain control.
I have nothing to add.
Great. Any questions from the audience? Someone's going to hi.
Hi, my name is Jen Brody. I'm a physician from Boston Healthcare for the Homeless Program. Do a lot of addiction medicine work there. And I just wanted to kind of highlight two bits of data that I'm really struck by. One is the piece of data that Dr. Burrell showed that showed us in the state of Massachusetts leveling off in terms of our overdose death rates overall, and then for our white demographic, but that among African Americans that number continues to climb. And then I also wanted to highlight the bit of data that Dr. Bonnert just showed us, that a very well-intentioned program to increase access to buprenorphine actually led to an increase in terms of inequities with the African-American patients not doing as well. And I wanted to just sort of bring us back to the opening comments, that if we fail to reckon with the structural racism built into our treatment system that touches every institution in America, we are going to see worsening outcomes, worse outcomes amongst communities of color. And I'm very interested, and I also just wanted to return to something Professor Beletsky said about the separate but equal treatment systems, and to talk about methadone as a treatment system and why it looks the way that it looks, right? Why does it look like a parole office? Why is it called liquid handcuffs? Why is someone's autonomy so restricted? Well, it's because it was designed for folks of color, in the 1970s, and buprenorphine looks very different. And that is about structural racism. And I just wanted to make this explicit, and I'm really eager to hear about how we're going to address the structural racism built into our policies and financing solutions. Thank you.
Let me start here, because I think it's really interesting that the data that you showed, Amy, is getting replicated here in Massachusetts. So Boston Public Health Commission just came out with a really interesting report that looked at receipt of treatment post-hospital encounter overdose, right? And it showed dramatic disparities among African Americans, particularly in Boston. And I happen to work at a medical institution that gets the highest number of EMS runs for overdoses. The vast majority of our patients are people of color. But if you look at the demographic who's in our treatment programs, they're white folk. right? And so I think we have an extraordinary responsibility as a healthcare institution to tackle this issue and to really think about it, not just, Haniar talked about the workforce implications, but that is, I think, one narrow piece of a much bigger pie. And I think we've got to figure out, what are the factors that are driving those kinds of disparities? I know that there are some other cities around the country that have been looking at this issue. New York City, Vancouver, and a number of places have been looking at this demographic, looking at kind of what they're using. Is it an older cocaine-using crowd where that fentanyl is in those, and we really haven't engaged them? Is it historic distrust of the medical system? Is it the fact that our treatment programs are culturally unresponsive? So I think there's a whole host of factors here that we really have to explore and then think about how do we really tackle those kinds of issues.
I think you're raising also a point that's even broader than the point on racism, which is I think when the history of the opioid epidemic is written, it will be a history of unintended consequences all the way across the board. It shows up geographically, it shows up racially, ethnically. It's unbelievably bad for Native Americans. They are hit the hardest. They have the worst track records there. But in terms of just our regulatory structure, every time we try to do something that we honestly believe will help, it winds up spiraling in ways that nobody ever anticipated. Abuse deterrent, OxyContin being case number one on that.
Question over here, please.
Hi, Jacob Rich from Reason Foundation. Dr. Bonner, you were discussing the program that attempted to expand medication-assisted treatment up in northern Michigan and other parts of Michigan, and you brought up the conundrum of just pharmacies not carrying the appropriate medications. And I was curious about what that says about the regulations that says we can only use buprenorphine and methadone for medication-assisted treatment, and whether expanding the scope of opioids allowed in medication-assisted treatment would help that shortage, and whether it might be better for outcomes in general. I've seen research on diamorphine-assisted treatment, which is just pharmaceutical-grade heroin, and it seems to be at least as effective as methadone-assisted treatment, at least by those studies. So I'm curious about your opinion on that research.
I think that's certainly an idea worth considering. I wouldn't say I'm an expert in all of the what the trade-offs are, and you just brought up unintended consequences. So I think that's the source of my hesitation. I'd like to think that something that may be a longer term goal, and I think I'm optimistic that the stigma-related issues are something that are more workable through a program on a shorter term basis. So we're working with those pharmacies and educating them, connecting them to other pharmacies that feel comfortable with their practices around. And I maybe overstate a little bit. It's not that they won't do it at all, but they want to have some relationship with the physician and make sure that they're not facilitating the work of what might be a pill mill, which you could unpack that in many different ways. But so helping build those relationships. So I think that's certainly a longer term solution, but I think I've been pleasantly shocked in doing the program how movable people have been on the issues of understanding the medications and understanding addiction as a disease rather than a moral failing. So I'm encouraged that I think that is possible. I don't know if you have additional thoughts.
As a physician and a prescriber, I think that the problem in pharmacies is an issue of education and stocking. And then when you go to places like the Upper Peninsula, the concerns become that there is less access to opioids. And we know that there are a number of break-ins and there's a lot of criminal activity around opioids. And so there's a fear at a pharmacy level. I don't know that pharmaceutical heroin is going to be more attractive to pharmacies in that respect, and there would still be an issue with stocking. And so I think this comes down to education and also demand. I mean, frankly, the reality is that some asthma medications aren't regularly stocked within remote pharmacies and take 2 to 3 days to come in because there's no one in the community that orders it. And so while I certainly acknowledge that there's stigma to the regular stocking of treatments for opioid use disorder. Some of this is education, and then part of it's demand. Question?
Hello, I'm Natalie. I'm a student at Harvard College. I wanted to build on a topic that Dr. Frank brought up, which is the role of Medicaid expansion in increasing access to treatment. I wanted to know what can be done from a financing perspective about making Medicaid expansion even more effective, given that right now physicians are reluctant to take Medicaid patients because there's lower reimbursement for the addiction treatment services. So what would that look like from a financing perspective if Medicaid were to really take this head on try to make Medicaid more of a viable payment system for addiction treatment?
Yeah, I think your point is exactly right. There is a payment problem in Medicaid. I mean, just psychiatrists are the lowest addiction psychiatrists are lowest participating group among all physician specialties in Medicaid. If you go to those treatment centers that I referred to in my talk, if you have a credit card, you get in immediately. If you have a Medicaid card, you have to wait a while. So I think all those things are true. Obviously one answer is bumping the price up, and some states have started to do that. And the evidence there is mixed. In what we learned from the primary care bump under the Affordable Care Act is it had small but not lasting effects. At least some of the initial evidence we've seen on some of the states that have upped their Medicaid fees for medication treatment of opioid use disorder makes you a little bit more optimistic. So as an economist, that's the first place I'd look, is pay more.
One of the things that Richard and I were talking about, as Amy was presenting, I was asking her as an aside, and I think Amy's experience in Michigan is true in a lot of other places, that it's more than just the primary care doc and the prescriber, that it really requires a care team. Many of those services are not reimbursed, right? So I was asking Richard, who's come up with a really good bundled payment for these kinds of models of integrated care? Because I think that's when we actually did a survey here in Massachusetts, because we had a significant number of people who went through the waiver, and we couldn't figure out why they weren't prescribing. And the two biggest things that they said was lack of administrative support and lack of nursing support, right? So I think it's yes, reimbursement's an issue, but I think it's part, and Amy, you can correct me if you think I'm off base on this, but I think it's part of this is that it requires a care team if you're going to have a significant panel of folks. Many of those services are not reimbursed.
Yeah, well, in the lesson from primary care treatment of depression, for example, is that even if you pay more, even if you change the codes, even if you sort of change some of these financial barriers, you really need to restructure the flow of care, the care within a practice. Otherwise, doctors won't have the time, they don't have the backup support, et cetera. And so that narrows the number of practices that are really good candidates for that kind of innovation.
Thank you.
Dr. Bonner described the pathway for this incentive for primary care physicians and other providers to do this for Blue Cross. And one credit to Blue Cross that I certainly didn't expect is those 10 patients can be of any payer type. So they could be 10 Medicaid patients. Blue Cross will still incentivize that care. And I think the rationale there is what we talked about is once you start doing it, it's rewarding work. You move past that concern, you learn, and then hopefully there's a net benefit, and I'm certain there's that thought. So I think, again, I'm not directly paid in any way, shape, or form by Blue Cross, but I think, again, it's actually a really innovative way to, and I understand the reactions in both directions, but I think it's innovative in that respect.
I just want to add, though, that there's a financial imperative here for Medicaid here to look at, and data here from Massachusetts, really showed clear and convincing data that if you get people on a medication, the entirety of their other healthcare costs go down. And actually, there's a duration effect, that the longer you can keep them on, the more you can reduce other healthcare costs, right? So as we're all looking at ways of how do we reduce that share of the states and federal Medicaid budget, it keeps proving out that not only medication is there's a clinical imperative, But there's also a financial imperative around Medicaid and Medicaid spend. So I think it's in Medicaid's interest to think about creating those kinds of incentive structures.
Potentially bundles, though, is that right? I mean,
Yeah.
Like potentially coming through with bundles for that care. That's great, thank you. Please.
I know we're nearly out of time. My name is Jacqueline Baba, and I'm a professor on the faculty at the Harvard Chan School of Public Health. And I wanted to ask a question which links the discussion on this panel with the discussion on the previous panel, particularly focusing on prevention. It strikes me that a lot of the models that have been presented really focus on the medical system, the healthcare system. But I haven't heard very much about the education system. And if we're talking about early intervention and about really accessing the broadest possible sector of the population, I wonder why schools aren't really central to this. If you talk about stigmatized populations, many stigmatized populations are wary of going even to primary healthcare centers, let alone hospitals. But school is really a universal service that is not stigmatized. And this includes Native communities, it includes immigrant communities, including undocumented communities. So I just wondered if maybe one or two of you could speak a little bit about outreach to teachers, outreach to students in school, destigmatizing opioid use in a school context.
I have a couple thoughts, and this is certainly not going to, you open a fantastic question that is, there's a lot of directions you could go with that. Maybe a simple superficial response is that I do know in Michigan, quite a few of the schools have had a movement towards carrying naloxone in their offices and are seeing overdoses occur in school property and trying to address it. That's obviously a kind of last mile solution to the problem, right? From a research perspective, thinking about the large HEAL funding initiative, I do know that part of that initiative funded prevention programs specifically geared towards teens. So there were 10 related projects funded all to try and reduce opiate misuse in teens. However, the large Healing Communities project that Jeffrey Samet talked about this morning, they actually, I believe, took out the school part of it because the primary outcome of that study is to reduce opiate overdose deaths and to do it in 4 years. And what you do in schools with teenagers will have a very long-term, decades long before you see an effect. So I think when their efforts are about addressing opioid overdose, the incentives for politicians to roll out a program and say, look, our state's doing so much better, we solved it, the schools aren't going to be emphasized in that because it's going to be hard for them to take any credit for what happens.
I think getting prevention funding for anything has been a problem, right? In terms of from a public health strategy, I think prevention does, and I think largely because it doesn't fit neatly into election cycles, right? You can't basically say I did this and you got this the next day. So I think primary prevention has always been a challenge, and I actually do feel as much good that we did at the federal level, I actually do feel a sense of regret that we weren't able to really amp up primary prevention dollars in terms of the work that we're doing. We had to, we had limited resources, and you have to hone it where you think you can make the biggest impact. And obviously mortality was like the big issue. The other thing I'll say, while schools do, I think we miss sight of the fact that parents are probably our biggest underutilized prevention resource. And I do think that there are good evidence-based, school-based programs, but I actually think we're missing the opportunity of working directly with family and parents around kind of their ability to really have and build resilient kids.
So Michigan Department of Health and Human Services did roll out a new opioid curriculum as part of the state health high school curriculum. So the 10 hardest hit counties just rolled out this fall, and we are working with them. There are members of our School of Public Health actually doing evaluations of that new opioid curriculum. And that's a longstanding, very successful health curriculum on which that's built. And we are actually proud to be working with them directly. We have a new musical that's now fully orchestrated that it's basically intended to kind of capture kids' attention. It's about opioid use disorder, loss, and recovery. And we will be hopefully rolling that in as an enhancement to the state curriculum. I think we have time for one more question from a very important person in the room, Dr. Bassett.
Well,
Welcome.
I'm venturing way out of my area of interest, although I would echo what Amy just noted. Certainly in New York City, where the goal was to reduce fatal overdoses, the target was not school children. And even a naloxone program in the schools was not justified by the data. But my question was about financing, and I thought of it when you mentioned that Blue Cross was paying for patients that weren't their own. And obviously a principal payer is public health insurance, Medicaid and Medicare. And I was at a meeting the other day where they were saying, you know, the ACO patients will get one package, and we're going to segment all of our patients' benefits by what insurance they have. And I wonder whether you could just opine on whether there's any possibility that public insurers would see a value of providing certain case management services to all patients, even though not all of the patients were their patients in terms of financial commitment.
Okay, I'll start on that one. You're the expert. The skunk at the garden party, yeah. Well, actually the opioid area creates an unusual opportunity because payment, ironically enough, is less fragmented here than elsewhere. Roughly 58% of the people with an opioid use disorder have incomes under 250% of poverty. And in spite of all the headlines saying it can happen to anybody, it doesn't. It happens disproportionately to poor people of color, and very low-income white people. And so because of that, Medicaid will always play an outsized role. And so, and also because it happens at the younger ages, and particularly for people leaving jails and prisons and people leaving foster care, you have an opportunity to really influence through payment the practices that serve those populations because they tend to cluster. And so I think that's another reason why getting Medicaid payment arrangements and ways to organize financing can have a disproportionate effect on this. And I wouldn't ever look to, you know, Michigan's, you know, people are nice in the Midwest, but for the rest of the country, actually, I can't imagine that you're going to, in a fragmented healthcare system, get Blue Cross or Aetna or Cigna to really carry that kind of load. Medicaid is the way.
No, so it's interesting, Mary, because one of the programs that we're looking at for our top 2% is a complex care management system, right? That you know, identifies people who are at the top 2% of expenditures. You know, these are the folks who are homeless, chronic medical conditions, untreated mental health and substance use disorders, and assigns them, you know, a nurse care manager and a community wellness advocate to help them navigate kind of the system. But quite honestly, the financials only work when with a very, very small select group of folks who are top utilizers. So the problem then does become, you know, what's the financial incentive then for those who are not in that kind of ACO risk category, and you know, where you can prove some return on investment.
Terrific. Well, thank you very much. Please join me in thanking the panelists.
Well, I'd like to thank the panel for getting us down to the brass tacks as we head towards the end of the day. And it's now my pleasure to invite our next speaker to the podium, Dr. Howard Koh, who is the Harvey V. Feinberg Professor of the Practice of Public Health Leadership at the Harvard Chan School of Public Health. He also holds an appointment at the Harvard Kennedy School. He's the faculty co-chair of the Harvard Advanced Leadership Initiative, and he was previously the 14th Assistant Secretary for Health in the U.S. Department of Health and Human Services. during the Obama administration. Dr. Koh's also been a huge help in thinking through this meeting, and thank you. Here's the podium for you.
Thank you so much, Dr. Bassett, for your heroic work in bringing together this great day. And I want to thank not only you, but Dean Williams, President Bacow, Dr. Brummond, all our colleagues from the University of Michigan, and especially each and every one of you in the audience, because this has been really a tremendous gathering and one that brings new hope to public health. I've had the great pleasure of thinking about health and working in the health arena for decades now as a clinician, as a former state health commissioner, as the Assistant Secretary for Health in the Obama administration, and now as a professor here at Harvard. I'm always asked to define what public health is. Today, I can summarize it in one line, and that is bringing new hope to an area where there used to be no hope. And having sat through the whole day, I hear many glimmers of hope that I think we can build upon to build better systems for the future. So if we can act on all the knowledge and commitment and passion today and build a better system for the future, what would it look like? What are the themes that we can build on to make progress go forward? I think I will focus on 3 themes in my 10 minutes. First is to humanize the issues, celebrate recovery, and tell stories. And many people have done that today. It was great to start with a person with a lived experience. I am so thrilled to be here with my colleague, Mike Botticelli, who has inspired me in his public discussions about his challenges of being in recovery over 20 years and serving the country, and now Boston Medical Center always inspires me. But I'll start with a story, which is about 15 years ago when I was a state health commissioner. I'll never forget, I went to an event where a woman was getting new housing after being homeless for a long period of time. She was wrestling with substance use. She was very poor. She was HIV positive. All of us public health folks gathered around her and several other clients as they got new housing. And as this woman got up and spoke, she started telling her story, telling about all her challenges, and then started thanking the crowd and said, "Thank you so much. You believed in me despite all the challenges I've been through." Then her ultimate line, which I still remember some 15 years later, "You believed in me when I didn't believe in myself." I've thought of that story 1,000 times, because that's what this is all about. People who are wrestling with substance use disorders need for all of us to believe in them and build a system to help them get there. And the essence of this is focusing not just on the substance at hand, opioids today, but there have been others in the past, and there'll be more tomorrow, but on the person. I'll never forget when my lifelong mentor, the late Reverend William Sloane Coffin, used to tell us medical folk, back when I was in training, that we should not consider a patient as just an uninteresting appendage to an interesting disease. In other words, focus on the person. And today we're hearing themes that we have to help people who are wrestling with opioid use disorder to get better treatment and care, of course, but these are people who are also wrestling with other challenges. Challenges of getting good housing, getting a good job, getting good schooling, rebuilding their relationships with their family. These are all the challenges that people with substance use disorders are wrestling with, and we have to be aware of that and support the whole person while we're also focusing on the substance. And no wonder that just in the last several years, there's been so much national discussion about substance use disorders as one of the newly described diseases of despair. Princeton researchers Case and Deaton coined that term. It's getting a lot of traction, and I think that's really positive because it drills down to the root causes of what's going on here, which is hopelessness and despair for lots of reasons, socioeconomic and others, not just medical. And so we have to keep that all in mind. And today what we've done, which is also very hopeful, is take another step forward, in my view, to view these issues as health issues and not criminal issues that deserve punishment. The second major theme I want to put forward to you is that when we talk about treatment, we should be thinking not just about medication, but also harm reduction and broader supports for all the reasons I just mentioned. It was said several times today, but I want to repeat, I have come to learn that when people are wrestling with substance use disorders, it's often multiple substances, not just opioids, but also we're hearing more about methamphetamines, benzodiazepines, alcohol, tobacco, other drugs. So this is where the harm reduction theme is very important. And the harm reduction theme, again, is person-centric, especially for people using IV drugs, because harm reduction is protecting people against HIV, against hepatitis C, but then also against all these other harmful substances that could impact their health. This is why I believe that getting recovery coaches involved, and I know there are a number of people who are involved in that here, so important. I've found recovery coaches to be some of the most inspiring people I've ever met in public health. These are people who have gone through these experiences, they have lived experiences, they have the life experience to tell people who are wrestling with this, I got through this, you can too, this is a lifelong process. And then doing this in collaboration with new non-traditional partners. It was great to hear Lieutenant Glynn from the Quincy Police Department today. I think the culture change in criminal justice we have just watched with great admiration over a relatively short period of time, because everyone realizes that we can't arrest our way out of this problem. And the way that police and criminal justice figures have stepped up, not only to supply Narcan, to make medications available, even if people present to police stations first, these home safety visits that were described, I think these are all ways to bring in new partners, and I think that's quite hopeful as well. We need heightened attention to these policy and financing issues that were described in this last panel. I had the great honor of serving in the Obama administration when the Affordable Care Act was born, now 10 years ago, this coming March. And we have all watched this saga here in Massachusetts that was the first state to implement health reform in 2006. We now have some 36 states that have expanded Medicaid, but that's not enough. We need this to go through all the states. We have to build better systems in that way. And then one hopeful sign again is that as we debate the Affordable Care Act and the future of health reform in our country, everybody agrees that the fee-for-service system, paying for volume, has gotten us to where we are in the United States. That is the most expensive healthcare system in the world, and not the outcomes to match. So what you heard from Mike Botticelli and Richard Frank and others about the future role of accountable care organizations, ACOs paying for value and not volume, I think is the wave of the future. If we can integrate these substance use treatment and prevention themes in there, that's going to be very, very important. And by the way, I thought Professor Bonnert's description of private plans paying for value in some of the examples she showed with Blue Cross Blue Shield was absolutely fascinating. We need the private plans to embrace this, and we have many that are taking a much broader public health approach to all this. And then the comments on litigation. I am one who started my public health career in the tobacco control area. I remember when the Master Settlement Agreement came through in 1998 and over $200 billion were made available. We all thought that public health was going to change dramatically because of that, and sadly we now look back many years later and just about all that money has been diverted away from public health. So as this litigation proceeds and these settlements keep growing, how that money is used is going to be a critical point of discussion for all of us. That money has got to be used for public health treatment and prevention. And then last but not least, I want to talk about prevention. I'm so glad Dr. Baba got up and made that key point, because prevention is the foundation of how to solve this problem moving forward. It's not easy. Prevention sounds easy, but it's not. As a public health professional, I have spent my whole career in advancing prevention and explaining what prevention is. It reminds me of a phrase that an ounce of prevention is a ton of work. But starting today, we have to talk about prevention everywhere we go, because health starts not just in the doctor's office, but where we live, labor, learn, play, and pray. I made that up, so I'll say that again. Health starts where people live, labor, learn, play, and pray. So starting today, we can talk about prevention of substance misuse where we live, at home, safe disposal of opioids, not just proliferating in the medicine cabinet, where we work. Every employer should be involved in these conversations because many employees are wrestling with these issues, whether people realize it or not. I'm so glad we talked a little bit about maximizing education here, not just in elementary schools, but in medical schools, in public health schools, in university-wide conferences like this one. We have great examples of research how educational interventions, particularly in elementary and middle schools, can decrease youth use of alcohol, cigarettes, and marijuana. And that's been in very, very good studies. And then also, I'm really delighted that we have members of faith-based organizations here, because faith-based leaders are tremendous public health and community leaders, and they can be great colleagues for us moving forward. So as I end, I really want to thank all the leaders for putting together this tremendous day. There's lots of hope here that we can build on. I particularly hope that we can move the conversation forward in future meetings on the importance of prevention, because I like to say that when prevention works, absolutely nothing happens and things are very boring. Let us all pray for a little boredom. And when prevention works, what you have is the absolute miracle of a perfectly healthy, normal day. Thank you very much.
Thank you, Howard, for those remarkable comments. At the end of the sessions that we've had this morning, a very nice culminating summary of the conversation so far. I also want to thank all of our speakers who've illuminated us with their research, with their professional knowledge, and their personal stories, their narrative. It's really been a remarkable session so far. And I'm sure I speak for all of you here in the audience when I say that today's summit, this inter-university summit, where we're at the crossroads of discussing the latest science and the ways and means for diminishing the barriers to help us improve and bring about solutions to this massive public health crisis. Now what I'd like to do is turn our attention to the closing conversation. And I'd like to reintroduce Dr. Mary Bassett and also welcome Harvard University's President Larry Bacow and ask them to please join us at the front of the auditorium to engage us in a conversation.
Well, gosh, I didn't realize that all the speakers had a light shining on them. Well, thank you so much for joining us. And I was so pleased when I heard that you wanted to have a conversation rather than treat us to another speech, which I'm sure you would have been happy to do as well. I just feel so dazzled by all that we've heard today. I'm lucky that Professor Coe gave us such a nice summary, as did our dean. We started out the day with somebody talking about their lived experience. We've heard from historians, we've heard from lawyers, law enforcement, policymakers, elected officials, appointed officials. Oh, I don't think we heard from an elected official, sorry. We did have government here. So we've had a whole range of people joining us today, and all of them highlighted, I think, the utility of having a meeting that talked about stigma. But you got this all started with with a conversation that you had with Mark Schlissel, the president of University of Michigan. So I thought rather than going immediately into all the complexities, you could just take us back to the beginning of the story. How did you decide that we should do this?
Sure. Well, first of all, let me say thank you also to all the speakers. Thanks to you and to Chad for helping to pull this all together. It's exactly what I think Mark and I had in mind when we cooked up this collaboration. So the origins of this, first of all, I knew Mark Schlissel, the president of the University of Michigan, when he was provost at Brown. And when I was named president of Harvard, in my remarks to the community, one of the things which I mentioned was that I hope to do a better job of connecting Harvard to the heartland, and that I thought it was important that we collaborate with our peer institutions, especially the great public universities, to try and address some of the most pressing and important problems which we as a nation confront. And the next day, I had an email from Mark saying, I read your remarks, let's get together and do something. So what followed was a phone conversation in which we agreed that we would look at a number of possible topics, and very quickly we settled on two, where we thought we had subject matter expertise at both the University of Michigan as well as at Harvard, and issues which were really important, not just to each of our states and our communities, but to the nation as a whole. And one is opioid addiction, and that's why we are all here today. And again, thanks to everybody who's participated. And the second was to bring together our faculties who are working on issues of economic and social mobility. And how do we ensure that the American dream continues to be a real dream for so many for whom it seems to have passed them by. And as I listened to the conversation this afternoon, they're totally and completely related. And so it's a real pleasure to be able to see what all of you have done with, let's face it, what was a half-baked idea that the two of us cooked up, but you really took it and have run with it, and I sincerely hope will continue running even farther.
Well, one of the things that's happened is within our own context, we've brought together a much wider array of people than simply the faculty at our own universities.
Right.
So this idea that you have of these two, an outstanding public university, an outstanding private university, and not just reaching out to each other, but reaching out to what is properly their constituency. Can you just say a little bit more about what your hope is that these are two high-powered universities? I don't, nobody would want to put us in competition with each other. These are two, really, well, you don't, because you're old friends.
Yeah, well, not only old friends, but I grew up in Michigan. I used to usher at University of Michigan football games when I was in high school. For our Michigan friends here, I can sing Hail to the Victors, but I won't. Look, I think that these are, all of America's leading research universities have much to contribute to the challenges which we confront as a nation. And God knows we confront many of them. Historically, I think we've been viewed as ivory towers, and I think we've gotten away from that, and that's healthy. The boundaries of our institutions have become far more porous over time. And I think that's really, really good. The kinds of issues which we are grappling with here today are systems problems. They're not going to be solved by any one intervention. They're not going to be solved by any one discipline. They're not going to be solved by any one profession. And one of the themes which we've heard over and over again today is the importance of narrative, of stories in changing people's minds and perceptions. To me, this is actually wonderfully encouraging in a time in which we hear so much about big data and artificial intelligence. It's actually stories and narrative that actually help people to come to appreciate what needs to be done, what has to be done. So I think as institutions, we need to collaborate in multiple dimensions. We need to collaborate with each other. That's why we are working with our colleagues at the University of Michigan. We need to collaborate with other institutions. That's why I'm delighted that our colleagues are here from Boston University, Northeastern University. We need to collaborate between the public sector and the private sector, which is why I think it's important that government's here. We need to collaborate with the nonprofit sector, whether or not we're talking about faith-based organizations or others. These problems are all bigger than any one segment of society. And so I think as academic institutions, we are capable of doing what we're doing here today, convening people to try and focus attention on really important problems, taking the best of the scholarly work that's being done, joining it with the work of practitioners in the field of all sorts, and then asking, how can we make a difference? Because in the end, institutions like this exist to make the world a better place. And that's why we do this.
Yeah, we got to clap for that.
Thank you.
It happens to be true. But we are always challenged to do better than we're doing.
Always,
And
always.
one thing that I've been wondering about is what sort of tools are within our hands, because, you know, much as we would like to make policy for this nation or even for this city or state, we can be advisory, we can help draft legislation even, or make technical inputs, but we do have some more authority over our own the way we treat our faculties, our students, and what we expect education to look like. And I wonder if we should be reflecting on how and I know you can only speak for the university that you're president of.
Well, I'll happily speak for the University of Michigan.
You'll speak for the University of Michigan. But I'm wondering what we can do to tackle stigma in our own ranks.
So I think what we need to do is that we, this is not true just here, I think it's in almost everything that we do. We need to model the behavior that we would hope to see in the rest of the world, right? So it's not enough just to do scholarship, it's not enough just to teach. We have to, I think, through our own actions, try and be living laboratories which demonstrate that change can occur, and to show how we can do better. That requires us, I think, also to be humble in knowing how we ourselves are capable of changing. Because, let's face it, we are often organized in ways that makes change difficult ourselves. As we talk about the problem of substance and addiction, we need to recognize that as institutions, there are many different parts. These problems, these issues, as scholarly issues, touch many different parts of the institution. At Harvard, we have people working on these issues here at the Chan School of Public Health, at Harvard Medical School, at the Kennedy School, at Harvard Law School, within the Faculty of Arts and Sciences. Do people always talk to each other? No. We can do better there. We can do better in trying to address problems of stigma of people within our own community who are suffering from these issues. We each have medical schools. We can do a better job of educating the next generation of medical professionals on how to address these issues. I could go on. There are lots of ways that we can imagine how we might do better. These are problems which, candidly, are not going to be addressed by university presidents. What people like Mark and I can do is we can give a nudge here and there. We can sort of say, here are, a few resources to try and get things going. But in the end, we need people like you to come back and sort of say, all right, here's what we've done, here's now what we need to do going forward. I always say any university that has to look to its university leadership for its good ideas is an institution in trouble. Most of the good ideas come from our students, our faculty, and our staff.
And from the communities that we serve.
Absolutely.
Which we've been hearing today. I mean, one of the really shocking statistics that we've heard is the very tiny proportion of people with substance use disorders who are in effective treatment. And additionally, we saw that even within that, there are very big variations by race and probably and by insurance status, which relates to income and who's. So we can document more of that.
Yep.
We can speak out about it. There are many people on the faculty who are participating in different ways. There are people on the faculty who are serving as expert witnesses in some of the trials that are still pending against pharmaceutical companies. And you were, when you were talking a little bit earlier, you were talking about how the tobacco settlement dollars, of course, it's decided state by state, isn't
Each state
it?
decided it differently.
Yeah.
And my understanding, and I should actually ask my colleagues from the University of Michigan, but my understanding is that Michigan devoted a considerable amount of its tobacco settlement dollars and sent it back to its universities to support research and work on some of these issues.
Well, what we
could all
don't want to
take a
see
page from
happening
that.
is just seeing it fill some anonymous sort of budget hole.
Exactly.
Well, maybe I should just ask you what you'd like to, if you thought about what you'd like to see grow out of this. I'm sure that what's going to be happening are the conversations that began in, around, and through the meetings. All of us have met colleagues that we didn't know before. And in that, have we sort of met your vision?
Well, I think absolutely you have, and I think I speak also for Mark when I say that, we hope that people would get to know each other across our campuses, that the relationships that were developed would be durable, and that people would continue to find ways to collaborate. I always say one of the reasons why we bring people together from different experiences, with different backgrounds, from different disciplines, from different cultures, is because we learn from our differences. And I hope we're learning from them here, and I hope we're learning from them in this collaboration. I hope it will stimulate us to think about ways in which we might collaborate, not just on this problem, but on other problems as well, because we live at a time in which I'm afraid a lot of people are willing just to wring their hands and sort of, or in some cases worse, just throw up their hands and say, I'm frustrated, I don't know what to do. But I think it's incumbent upon all of us who have been blessed to work in institutions of higher education, who've benefited from having many of the advantages of being able to work in an environment which we have the privilege of working on problems because we think they're important and important to us, that we try and help lead the way and show how we can do better going forward. We will not always get it right, let me say, and we've heard about, in the hour and a half that I was here before this session, we heard about a lot of things that didn't go well. Policies that were tried, policies that failed. The challenge in life is to make new mistakes. And we should never hesitate to keep trying, because it's through that process of trial and error that I think that ultimately we will find paths forward that help us to address problems like this one.
What always keeps me optimistic is so many of the problems that we confront have more to do with our society than with our biology, thank goodness. And that means that we can change it.
We
and as people who are training the next generation of leaders, we can convey that this isn't baked into our lives, that we can change it. And we can help them become thought leaders and contribute to the policy debate.
But
I hope we've done some of that.
I think we have, but also as we think about educating leaders, because both of our institutions hope to do that, we have to educate leaders who are humble and good listeners and who are willing to learn from everyone. And I think one of the things which I come away from today's conversations is how much we can learn from those who've struggled to address these problems and address them personally. And again, to those who've shared their experiences.
Thank you for that. Thank you. I was just going to look at my list to see if we covered most of the questions that I thought that we might. And you know, we have.
Good. Well, why don't we go out and enjoy a reception and have a
So,
chance.
I
I'm
wanna
looking forward to
thank you
meeting
for-
others. And again, to everybody, Mary, especially to you and to Chad, thank you for
Yes.
pulling this together and for making this possible.
And I want to thank the audience for being so attentive, asking great questions. And although Chad did it for me, I want to thank in particular the people from my small center at that is housed at the Chan School of Public Health, Veronica, Rebecca. Why don't you just stand one last time? Next time you'll have a glass in your hand. Thank you. And thank you, everyone. Thank you, President Bacow, or Larry. Thank you. Thank you very much.